Okay, we have about 10 minutes left, and I wanted to invite the remainder of the panelists, George Solomon, to come up as well, please. The title of this is One Energy, Can One Energy Do It All? So we have a number of experts up here. I know we have some folks in the audience that are still trying to figure out how many and which ones they need to build into their armamentarium. It's a very mundane question. So what we'll do is we'll just go around and ask some opinions. The first question will be about perhaps where you live, which energy sources you use, which ones are paid for. Just a big picture view. We'll start with Dr. Solomon.
So to start, which energy I use or?
Insurance coverage, reimbursement.
Insurance, sorry, I was just looking at this. So the problem in Germany is actually, compared to US, that as I work in a university, we get like 3,700 euros per case. And that's not all. They have to stay at least 3 to 4 days in the hospital. There's no surgeon fee or nothing. So if you want to have a cheap HIFU, come to Germany, and you will pay less than 4,000 euros.
And what's your choice of instrument?
The choice of instrument is HIFU at this moment, but anyhow, we look for some other energy for anterior tumors and for the distal apical tumors, which we cannot treat with HIFU.
For which patient do you indicate double tap with the HIFU?
So my colleague Yamini Nagaraj, she and we do HIFU both, and she did a very good job. She published at AUA the abstract about double tap, that at the beginning, like almost 10 years ago, we did this contrast enhanced ultrasound checking after the first tap. And after 2 years, we checked the results, which patients had a double tap and which not. So the positive contrast enhanced patients, they got a double tap, and we saw that they run better. So we decided to skip the contrast, save money because we just got 4,000 euros, and do a double tap in every patient. And interestingly, the rate of biochemical of the recurrence in the infield went down from 14% to 6%. So that's pretty good data on the double tap.
Thank you. Laura, your turn. The insurance coverage and what instruments do you use?
In my institution, we have access to HIFU, IRE, and cryo. So nowadays, we go for one energy or the other based on the lesion location. So none of them is reimbursed. So it's the hospital that pays, not the patient. And maybe HIFU is going to be reimbursed with a HIFI study in the coming months, but it's not the case for the moment. So nowadays, I decide the energy I'm going to use based on the lesion location.
May I ask, how much do the insurance companies pay for example, HIFU or whatever?
Honestly, I don't know that. I don't know how much they pay for that.
Okay, I have to know because our CEO will say, George, don't do that much HIFU because we block it now.
Do you think that the a la carte approach will survive when you get more experience?
No. In fact, I do that because I have access to all the energies, but it doesn't mean that you have to use 3 energies to treat the whole gland. I mean, if you have experience and expertise enough with cryo, I think, and I have seen some papers that prove it, that you can treat all the lesions in the prostate, but you have to have the experience.
Dr. Rothberg?
So I'm at Duke in North Carolina, and we have a couple of different options for focal therapy. I offer HIFU and IRE. Tom, you do cryoablation. And coverage from an insurance standpoint is variable from one private payer to the next. And so it's sort of a guessing game from one patient to the next, which insurance company is going to provide coverage and reimbursement. In some instances for patients who are good candidates for irreversible electroporation focal therapy, there is a CMS code for that. And if they are Medicare patients, I'll have a discussion about, their eligibility for focal therapy and what approach is appropriate for them. And then sometimes we'll pursue that based on, high likelihood of it being covered. But in general, it's kind of a grab bag and a mix from one private payer to the next who's going to reimburse in our region.
Okay, Dr. Stricker, we know you use IRE, but what else is available in Australia, and can you make some comments about coverage and cost?
So I can probably speak about Australia and New Zealand. We treat a lot of people from New Zealand as well. There is no reimbursement at all for any of their technologies. So that includes, in Australia, we have available HIFU, and Shelley Varol's been doing some laser therapy. Jeremy Grummett's been doing focal brachytherapy under a trial, and I've been doing IRE, and I've trained a lot of units around Australia, they do IRE. But to my knowledge, unless you're in a clinical trial at the moment, it's not reimbursed. You can speak to reimbursement companies in the salvage setting, and on occasions they will actually cover it. But it's usually veterans that are covered.
Dr. Pausang?
Yes, that's interesting because I didn't know there were so many differences around the country. But fortunately in Florida, all are covered. We have HIFU, IRE, and cryo. For us, it's practical. We're fortunate enough to have a big referral center. So it's a matter of workflow and efficiency. So the way I think about it is I use cryo, I compare it to a grenade. If you want to treat a large area, I use cryo. IRE are equate more like a sharpshooter, if you want to hit a target. And HIFU, I'm very selective for very posterior areas. Interestingly, Tulsa is not covered, but it's available in Florida. So we send them to Dr. Shionti or the Mayo Clinic.
So Dr. Bianco, I have a different question for you.
I was going to ask to Dr. Pausang. So when you do the IREs, do they cover your professional component as well?
They do.
They do. So they split the payments, technical and professional?
No, they're both.
They're both. So you can, okay, good. That's good to know.
So there's a number of modalities available. Which ones do you feel can be done in the office, keeping patients comfortable? Which ones are those?
So we know for sure that you can do cryo and you can do transperineal laser ablation. So we completed a trial with 30 patients. It was well tolerated. We did not have to abort any procedure with laser. And the key there is to understand more, the extension, and the monitoring is more of a challenge compared with compared with laser. But those two for certain, and I think there's some emergent technology, derivatives of IRE, where you don't need to paralyze the patient, that it may be, worth exploring down the road.
I just had a comment. I don't know if you guys are aware, I think we're all moving to Japan because the reimbursement for a fusion biopsy is $6,000 US, and for a focal ablation, it's $40,000. So that's paid by insurance. Make sure you get your passports updated. Focal therapy meeting is going to be there in 2026 as well with Dr. Ukimura.
I wanted to thank all the panelists. This was an exciting session, and we want to move on to the next presentations. Thank you.
Phil, let me ask you, so those salvage